on the vestibular schwannoma microneurosurgery. This is just an update on 260 cases we treated in the last years. So this is a disclosure, you know. At first, I would like to present our algorithm to, for the treatment of the vestibular schwannomas. Usually we consider two items. The first item is the size of the tumor, if cause, according to the cause grading scale, and then the hearing preservation or not of the patient. So if we have patient with the hearing preserved according to the American Academy Otorhinolaryngology head and neck surgery classification A and B, so good hearing, I mean, we can treat differently the patients in relation to the general status according to the scale of anesthesiologists, American anesthesiologist scale of health. Patient in bad conditions, we prefer to wait and scan, and in case of growing of tumor, we prefer to treat with the radiotherapy, send to radiotherapist. In cases of good hearing and good general conditions, we prefer to treat surgically the patient with hopefully a total or near total resection, and in this case we follow up the patients for years. But in case it is not possible to treat with the total excision, we do a subtotal or near total excision and wait and scan the patient for the follow-up. And we decide in case of regrowth to retreat surgically or send patient to radiotherapy. In case with hearing not preserved, the size of tumor is important, of course. Patients with big tumors like COS 3 and 4, we treat always with surgery. Cases with smaller tumor, in stable or no symptoms, we prefer to wait and scan. But in cases of growing or symptomatic with other symptoms of tumor, we prefer to select the patient according to the general condition. Again, patient in bad general condition, we send to radiotherapist. But patient in good conditions, we prefer to operate. Another selection we do according to the age of patient. Especially in patient older than 70 years, the size of tumor is very important because people with small tumor, but aging 70 or more, if they have no symptoms, we wait and scan. But if they have some symptoms and the congenital conditions are very good or quite good according to the age of patient, we decide to operate with microsurgery. No other possibility in patients with big tumors. With COS 3 and COS 4 acoustic neuromas, we always treat patients with microsurgery. Of course, the bulking and the removal has to be judicious, and we sometimes prefer subtotal removal and follow patients for months and years. If there is no growth, a follow-up, we wait a scan. But if there is some growth of tumor, we probably prefer to send to radiotherapy. These are the 10 key points that we follow for the vestibular schwannoma surgery usually. We prefer the Fukushima lateral position. I will explain later, of course, every point of this technique. We always do a keyhole opening with the micron super technique. In our cases, we aspirate the CSF from the lateral medullary system in order to obtain relaxation of the cerebellum. Then we try to be clean, bloodless, and we try to use always the sharp dissection. Another key point is maintain as long as possible the arachnoid plane. It's like a holy membrane, we call this arachnoid plane. Then in all cases, especially big tumors, we do a sufficient internal tumor debulking. Then we always try to identify the position of facial nerve using the intraoperative stimulation. Then we have to elevate the capsule using a special technique I will show you later. In all cases, we try to preserve always, ICA, pica, and perforator, so all arteries, but most of all, we try to preserve the vein and especially the petrosal vein in order to have no complications after surgery. And the main goal in the majority of cases is to give the patient a normal face. This is the updated series, our 160 cases updated in terms of follow-up. As you can see, the mean diameter is about 2.6 centimeters. The grade 1 are a minority, less than 10% of them. The majority of cases are grade 3 or grade 4. The mean age is around 50, and as you can see, there is a strange difference. We cannot explain it completely, but as you can see, people with 25 years old or less have a larger tumor than older patients. Probably partially because there is a quote of patients that belong to the NF2, but not always is NF2 patients. The young patient with a huge or large vestibular schwannoma. As you can see, our follow-up, minimum 6 months follow-up, has more than 90% of people with HB1, so normal facial function. 5% with HB2 or 3, and 3% with bad result. The result was different in relation to the position of facial nerve in the CP angle. I will show you later the possible position, how we detected in several cases. And I mean, now in all cases, but we published a selected series. As you can see, the worst result we have in terms of facial function, long-term facial function, is when the facial nerve is not immediately visible. So when it's ventral, totally on the opposite side of our point of view. This, in these cases, the good result was possible in 84% of cases. In 73 cases, we tried to do an hearing preservation surgery because the starting hearing was good. And we obtained a hearing preservation in more than 60% of cases. And in these cases, the maximum diameter was in the end 1.9, about 2 centimeters. So the summary of results are the following. The facial function was good, more than 90%.
Subito un intervento neuronoma di neurinoma una settimana fa e è andato bene, potete vedere riesco a sorridere
The blood loss
e ci sento.
No permanent cerebellar dysfunction, only time to time transient vertigo. Resolved with the simple drug. So these are the most important instruments we use for vestibular schwannoma surgery. So we have a set of micro-scissors with thin blade, very thin blade, several hook knives, sickle knives, and all the different cutting edge instruments. Then we have a cup curette of different sizes, tumor forceps dedicated, and some sharp other dissectors. Then during surgery, we use several tools in addition. So the facial nerve intraoperative stimulator and the ABR in case of hearing preservation surgery. Then we have the Sonopet ultrasonic aspirator, the handheld laser fiber, and the flexible endoscope for the final check inside the internal auditory canal. I will show you all these tools and all these instruments working. This is the position we use normally for this kind of surgery. This is the so-called Fukushima lateral position. So as you can see, the body of patient is oblique, and the head is maintained in a naked 3-pin holder. Under the axilla, we always put a silicone pad, and you can see very well how the superior upper arm is positioning just for opening this angle in order to avoid any obstruction to the surgeon for reaching the target. Normally we do a striato-acute incision of about 5 centimeters and prepare in any case fascia graft for the final dura closure. This is the craniotomy we do, is normally 3.5 square centimeters. And we have as some markers like the superior nuchal line and the inferior nuchal line. And the craniotomy is inside these 2 lines, as you can see here too. And always we try to expose the sigmoid sinus and the transverse sinus, always. This is the surface of the dura mater, and we open the dura mater in order, we try to open the dura mater in the lower portion. In order to open the lateral medullary system for obtaining the CSF aspiration. This is a very relevant step, a very fundamental step for this surgery, because the decompression of cerebellum is fundamental for retracting or holding, better done. We don't retract cerebellum, we hold cerebellum. Now you can see in this case how the CSF aspiration had produce a decompression of cerebellum. We have just to put a cottonoid and gently retract the hemisphere and have a view on the tumor. There are different possibilities of cutting the dura. We prefer the yellow one, but I mean, it's not very fundamental. The next step is to try, especially in small tumors, try to localize the position of facial nerve. As I told you before, this position is changing case by case in 3 or 4 categories. I will show you immediately later. In all cases, we try to detect as soon as possible the position of fascia. In this case, was quite easy because of small tumor, you can see immediately the fascia nerve. In big cases, it could be, and I show you in other slides, very difficult to localize and separate, separate capsule from the nerve. In every case, especially big tumor size, is a fundamentally maintaining the arachnoid plane. And these are the possible position of facial nerve in the CP angle. We try to stimulate with a different amperage in relation to the moment. I mean, on the capsule at the beginning, we can start from 1 milliampere to 5 milliampere in large vestibular schwannomas. But on the nerve, we stimulate maximum 0.5 to 0.01 milliampere directly on the nerve. In 100 consecutive cases, we found that the anterior superior position of facial nerve was detected in about half of cases. An anterior, I mean ventral, totally ventral position in 1/3 of cases, and anterior inferior in about 20% of cases. In these 260 cases, we found only 1 dorsal case, and this is a very bad condition when you have for all the time during surgery your facial nerve in front of you. The dorsal position is by fortune very rare, but it's for the surgeon and of course for the result of the patient, a bad condition. This is the method I described before. I told you before, for identifying the position of vestibular nerves, superior and inferior vestibular nerves, that delimitates the core of the tumor. So we cut with scissors, or as I'll show you on the right side with laser, the surface of tumor in order to identify the superior and the inferior vestibular nerve. Of course, one of these nerves, usually the inferior, but sometimes the superior, are the origin of the tumor, and we can see during this maneuver which is really the native nerve of origin of tumor.
Ultrasonic aspirator is
Then
of the
another step
right side operated
the
in the
opening
facial
of the
nerve that is
internal
located
auditory canal.
anterior. Opening of
This
the
movement
internal auditory
show
canal
how we
is performed
normally
in
do
the first step by means of trillium laser fiber
First,
that is used
we
to
open the
coagulate
dura covering
dura
the
mater
meatus
of the posterior aspect
with
of
the
petrous
laser.
bone in order to detach it and gaining access to the roof of the internal auditory meatus. Second step
Then we
is the
open
unroofing
the
of the
bone,
internal auditory
cut
with
the bone
ultrasonic aspirator
with this
with bony
ultrasonic
dedicated
aspirator
tips,
with dedicated
allowing a gentle
bones.
shattering of the roof. During this stage, we should keep in mind the fundamental anatomical landmarks
And these
in
are
order
the
to perform a
anatomical
safe
landmarks.
or preserve the jugular bulb and the labyrinth structures. During this stage, unroofing of the internal auditory canal is performed above dura mater of the auditory posterior aspect of petrous bone that is now coagulated to expose the tumor capsule to the cerebellopontine angle. After this stage, tumor
We remove
resection
the
is
portion
further
of tumor
performed
inside the canal
in the
with
internal
dedicated
auditory canal.
instruments and curettes.
Therefore, additional drilling of the roof of the internal auditory canal is performed, being careful not to damage superior and posterior semicircular canals located
try, of
in
course,
the
to
lateral
avoid the
portion.
names
During
of
this
the
section of the
canals.
internal auditory canal,
From time to
low
time, we
amplitude
test the
nerve
function of
stimulation is
facial nerve.
routinely used to detect the facial nerve. Tumor resection is further pursued by means of hooklets, curettes, and microsurgical scissors. At the end of the resection, a thin layer of tumor capsule is left. More recently, at the end of resection, we perform a short flexible endoscopic inspection of the internal auditory canal in order to detect possible tumoral residue located in the fundus. In conclusion, according to
So as you have seen in the movie, we use several instruments for remove the tumor inside the canal, some different instruments and curettes and several knives and other instruments.
In this video, we present
this
an
is,
endoscopic
really
dural incision is made near cerebellomedullary system to obtain CSF leakage and cerebellar relaxation.
The pure endoscopic.
Complete dural opening is obtained and cottonoids are placed on the cerebellar surface in order to avoid damage during operation. Gentle retraction is performed in order to expose structures of the cerebellopontine angle. A trillium hand laser fiber is used to coagulate the dura of the petrous bone above the internal auditory canal that is then detached in order to open the posterior wall of the internal auditory canal by means of sonopet ultrasonic aspirator with dedicated bone tips that produces firing of the facial nerve after electrophysiological monitoring, and then opening of the internal auditory canal is alternative performed by means of 5mm high-speed drill.
Sonopet can produce some disturbances to the facial nerve, probably.
Dura mater of the internal auditory canal is then opened and coagulated by means of laser fiber.
Ultrasonic aspirator and the drill in order to avoid damage.
Low amplitude simulation of the facial nerve is then performed to identify its positioning into the internal auditory canal. Progressive detachment of the tumors from vestibulocochlear nerve is obtained. A microsurgical dissection is performed by means of hooklets, microsurgical scissors. Canal. booklets are used to look for residual tumor in the medial portion of the canal. Further drilling of the posterior wall of the internal auditory canal is necessary to obtain a satisfying resection. The flexible endoscope is then inserted under microscopic vision in the surgical cavity in order to check the extent of resection and revealing residual tumor in the lateral portion of the fundus of internal auditory canal.
And then we know where this
further microsurgical resection is then performed, guided by the previous endoscopic control.
And second check for confirming the total removal.
The second endoscopic control confirms that gross total tumor resection has been accomplished.
This is the final view after the hemostasis. We normally do in a very accurate way using several methods. And at the end, as in this case, we usually see the trigeminal nerve on the superior side close to the petrosal vein, the facial nerve from the brainstem, and the cochlear nerve. The surgery is clearly difficult, more difficult in large vestibular schwannomas. I mean, the cause grade 3 and 4. This kind of tumor have sides larger than 3 centimeters and sometimes 4, in selected cases also 5 centimeters of maximum diameters. In this case, we always do a generous internal tumor coring at the bulking with sonopet, laser, and other micro instruments. Also, the setting of sonopet is a key point. So we cannot use an excessive suction. We have to use the minimal suction because we don't know, especially with tumors, where the facial nerve and other nerves are. And we have to reduce at the minimum the suction, and also the power is the half of the normal power of the instrument. This is our report on 60 cases, published just now in the last year. This is one of our cases of post-grade 4 hypervascular vestibular schwannoma. These tumors frequently are hypervascularized. You can see on this side the stimulation of facial nerve and the facial nerve from the entry zone in the pons, and then here there is the confining. I mean the tumor capsule just adherent, seems to be adherent to the facial nerve. But with some patient and some good instruments, we try to detach the tumor capsule from the facial nerve. And again, we continue to detach, sometimes sharply, sometimes not, blunt the capsule, also inside the internal auditory canal. And at the end, this is small remnant of tumor we can remove it quite easily. And the facial nerve is totally intact. And as you can see, the removal was complete. So the results of this series of 60 COS4 vestibular schwannomas are mostly in relation to 2 factors: the adhesions, sometimes intense adhesion of capsule to the nervus and brainstem, and of course to veins and to arteries, and to the bleeding of the tumor that is related to the vascularization of this tumor, that in the majority of cases, I mean more than half of cases, is hypervascular. So we preserved the facial nerve in more than 90% of cases in the anatomical point of view. But in the whole series, I mean in the all 60 cases, we had success, I mean HB1, HB2 in about 72% of cases. If we consider only the last cases operated on in the last 5 years, this result is quite better, is 90% of cases with a good result. You can see that the stimulation, the mean stimulation at the end of surgery can be predicted of the result. Usually, if we had a stimulation less than 0.3 milliampere, we can expect to have a 6 months and later HB1 result. If the final stimulation is more than 0.3 to 0.5, probably HB2, and worse for higher stimulation. One of the problems of the small opening in posterior fossa is the complications, post-operative complications, especially the fistula and the CSF under the wound and some infections and so on. You know very well the possibility of bad results related only to the closure. And at the beginning, we had not fantastic results. And so we tried to follow the suggestions of some giants like Takanori Fukushima that suggested me, please try to do this kind of technique. So the fascia that we harvested at the beginning of the surgery, now we put, as you can see, like an hourglass shaped way, and we stitch this fascia under the level of the dura in order to have a watertight closure. And after the introducing of this technique that we published some years ago, the possibility to have after operation some CSF related complication now is very, very low. By fortune, this was the key of our post-operative success. It's very rare that we have a complication like this. After this closure, we put some tacosil over the dura. I'll show you. You see, this is the tacosil that is fitted on the craniotomy. Of course, some bone wax is always necessary to close the cells, the mastoid cells, to avoid the renal liquoria or other CSF leaks. And then some Sagicel, just to complete. And then above we put, of course, the bone. Some nuances for the preservation of nerves. I told you that we are very happy of our intraoperative neuromonitoring, both for facial nerve and the cochlear nerve. Both this stimulation of facial nerve is very effective. Now we use the monopolar stimulation. We started with the bipolar in the first cases, but we moved to the monopolar stimulation and continuous EMG recording of the nerve during the surgery. And then we do the intraoperative IVR in all cases in which we had to try the hearing preservation. In the post-operative periods, we use high dose of steroids in the majority of cases for maintaining the microvascular supply of the nerves. But in some cases, the facial nerve preservation and other, of course, important function preservation is obtained with a millimetric residual capsule, and sometimes much better, because if adhesion, as I told you before, is very hard, it's very tight, member do not go over and leave some thin millimetric residual capsule and follow up it for with MRIs for years. As regards the cochlear nerve preservation in the selected cases with good preoperative hearing, we use, since some years, we published several articles. This is the first we published in 2015, a new method of stimulation. I mean, the standard ABR with click had some limits, and this new method of stimulation that many audiologists and the ENTs, they know, is the C-SIRP stimulus. This C-SIRP stimulus has the capacity to stimulate all the cochlea and not only part of the cochlea, but all the cochlea at the same time, like an orchestra starting to play all together, and all the cochlea is stimulated. And this you can repeat every 20 seconds, and the answer to the surgeon during the procedure is quite quite fast. So if I ask to the neurophysiology to have a C-CIRP, I mean an ABR, the C-CIRP is so fast that we have the answer of the hearing status in after 20 seconds. Other items we do the use of intrasystemic diluted papaverine, I mean hydrochloride. The topic used in neurosurgery is very common. We started to use with intracranial aneurysm in order to reverse or prevent intracranial arterial spasm. And this is very effective, especially in the microvascular net. And so in the macrovascular net of nerve is the same. We had a personal series, not published series of 94 cases in 5 years. And in this series, the results in terms of facial nerve and healing are quite good. Then during the washing, normal washing during surgery, we use water, saline solution with steroids inside, so diluted steroids washing. And then, as I told you before, we use for 10 days, 15 days, post-operative steroids at high doses. I told you about the utility and the safeness of the handheld flexible laser fiber. Now we use the thulium laser at the beginning. We use also the CO2 laser, but we prefer to move to the thulium laser.
Professor, can you little raise your volume? Just if you can raise up your volume little bit, we'll appreciate it.
Thank you. So this is the time of a flexible laser fiber. I told you that this laser is safe, and then it facilitates the resection, especially in difficult conditions. I mean, highly vascularized tumor, large tumor, hard tumors. And if we focus, especially in these cases, the thulium laser seems to be very useful and safe. Then we use in the operative period also the nimodipine, as suggested by the CNS evidence-based guidelines. This is a recommendation of the CNS. And our series is 68 cases, and we had very good facial nerve results at 6 months in the 64 cases. So we have not published this, but probably in the next future we try to review and publish this data. So nimodipine seems to be very effective for maintaining the vascularization of the nerves after surgery. During the last year, several studies tried to introduce some drugs, especially COX-2 inhibitor, in the treatment or adjuvant treatment of acoustic neuromas, vestibular schwannomas. But in effect, these trials failed. For sure, aspirin, I mean, ESA, it was not effective on the growth, on stopping the growth of the acoustic neuroma. Some dopes we have in the residual, but probably not. Other drugs like progesterone inhibitors and the glucocorticoid antagonists, they tried to use without big success. Very interesting, and we are trying to start with this, are studies that are projected to the visualization, preoperative visualization of possible position of the facial nerve, and this is possible with the GTI on MRI. So the tensor imaging technology probably will help us in predict the possible position of facial nerve. These are some published articles of Chinese and Indian groups. It seems to be an interesting way for predicting the result of facial nerve in relation to the position of the nerve. So in conclusion, usually vestibular schwannoma requires surgery. In some cases, as I told you at the beginning, we prefer to wait and scan, especially in small tumor in old and deaf patients. In these cases, if the tumor grows, small tumor in old patients grow, we probably send to radiosurgery. But this is probably the only situation, because normally we try it with surgery. The total and near total removal is possible in a majority of cases with preservation of partial nerve. In selected cases with good preoperative hearing, especially if the diameter is less than 2 centimeters, it's possibly to try a hearing preservation surgery with the 2/3 possibility of success. And then the last consideration is that the microneurosurgery can cure vestibular schwannomas and radiotherapy not. Thank you so much for your attention. And this is our book on advances in vestibular schwannoma microneurosurgery. So you can find also some info or contact me by email or by Instagram or on my website. So thanks a lot for attention and for this possibility to present you my personal experience. Thanks a lot, Professor Mohammed.
Thank you very much, Professor. Really, I have enjoyed the presentation and many new information, and it seems that you are a master with your team. I have few questions for you, Professor. So the first question, what about the translabyrinthine approach? Do you recommend? There is some literature which recommends the translabyrinthine approach than the other approaches. So what's your opinion about this?
Yes, thanks for this question. So I do personally the translabyrinthine approach in some very selected cases, especially in some old patients with huge tumor, large tumor. In this way, I have not the needing of preserve the hearing, so I can do by translab. I can debulk as much as possible the tumor without see and without touch the cerebellum. This is a possibility, and we do in very, very selected cases. But in the majority of cases, we prefer to do the retrosigmoid because we can control much better, because we are, of course, neurosurgeons, but we do both. But in the retrosigmoid approach, we can control better some adherences to veins and to arteries in the face. I mean, when facing the capsule of tumor, the brainstem. Anyway, I told you, in selected cases, fragile patients, we prefer to use the translab. This is true. This is another weapon we have. Sure.
We have a question here about what about the long term, which means more than 10 years, percentage of recidive after total gross removal.
Yeah. Thanks. This was the topic of one of the last article. I mean, one of the last manuscript we sent for publication, and this is a problem of a huge tumor, big tumor. In the small tumor, I mean, under than 2 centimeters, we don't have recurrences at 10 years. In larger tumors, we had some recurrences, about 4% of cases, because of the necessity in some of them to leave fragment of tumor because too much adherence to the brainstem or to the facial nerve. So we have recurrences in larger tumor. After we have a main follow-up of 8 years, and in this time of follow-up, we had 4% of recurrences that we have to take in account. This, of course. So the low percentage was justified by the propension to try to remove as much as possible. But some subtotal or partial, very few cases of partial removal, you have to expect after long-term follow-up to have a recurrence, and then you have to decide if to retreat surgically or, especially in old people, to treat with radiotherapy.
Professor, sometimes we see in our clinics the neurofibromatosis type 2 patients with bilateral vestibular schwannoma. So what's your experience about those patients?
Yeah, normally these patients are unfortunately very young patients, and they have other tumors associated very frequently I have different experiences. I mean, some cases are quite lucky patients. I mean, because they have only benign tumors. In some other cases, they have also malignant tumors, and this is a very worse condition. In any case, the tumors, the vestibular schwannomas in this case are usually very aggressive, more than the occasional vestibular schwannoma. The NF2 vestibular schwannomas are very aggressive, very vascularized tumor, bleeding tumors, and they recur much more than the other occasional tumors. So it's a very bad condition. I follow several guys with this tumor since some years, and in some cases a very sad condition, especially when they become deaf bilaterally. So this is very sad.
Professor, in your experience, all of us know and read about the post-vestibular schwannoma surgery, imbalance, vertigo, unsteadiness, and postural instability. Hello?
Yeah, I'm here.
So 2 points. You use post-operative steroid, which is known for us to enhance the vestibular compensation. How is your experience about the vestibular symptoms after the surgery?
Patients who don't have before any vestibular symptoms can experience after surgery for some days or weeks vestibular symptoms. In a very minority of cases, we continue to see these vestibular symptoms, vertigo, imbalance, for months. Usually after some weeks, they stop. On the contrary, patients that had before or have before surgery dizziness and some imbalance and other vestibular symptoms, they magically stop these symptoms. So there are two different behavior in relation to the symptoms, preoperative symptoms. Patients who don't have any vestibular symptoms, they can have postoperatively and temporarily some vertigo and something imbalance. Patients that had before surgery these symptoms, they don't have anymore after surgery. This is my experience.
Thank you, Professor. One more question.
Professor, excuse me. Hello, I am Susan. Can I ask a question?
Hi. Yeah.
First, thank you for your presentation and for this meeting. Professor, in some large cases of neuronome acoustic with obvious compression on trigeminal nerve in MRI, in some cases, the patient have symptom of numbness, but in some cases there is not.
Yeah. Thanks.
What is the theory behind that? And because I know you have some research, and what is the prognosis?
Thanks, Susan, for this question. In some cases, in some huge cases, in many of these large cases, we see a contact on the MRI between capsule of tumor and the trigeminal nerve, but not in all of these cases we have trigeminal symptoms preoperatively. So we asked with my fellows which is the reason, because some of these cases have and some other cases have not trigeminal symptoms. Then if you consider the dissection during the removal of a giant tumor, and Susan, you see several times in the
yes,
we sometimes we have a membrane, a arachnoid membrane, that is separating the capsule of the tumor from the trigeminal nerve. In these cases, we have not trigeminal symptoms. But when this arachnoid membrane is not present, and the tumor is directly in contact with the root entry zone of the trigeminal nerve, in these cases, we usually have trigeminal symptoms. Trigeminal symptoms that could be pain or simply numbness or other more, I mean, not so severe symptoms, but this is the difference we found. And this is the research of one of my fellows, Fabio Boccacci, that I think is following us. And he did a great job in selecting these cases and evaluating the differences. And the differences is just anatomical difference in relation to the presence or not of arachnoid membrane in between capsule of tumor and the trigeminal root entry zone.
Thank you, Professor.
Thanks for the question.
One more question, Professor. Sometimes patients present lately with associated hydrocephalus. So would the management be different in the presence of a secondary hydrocephalus in cases of vestibular schwannoma?
Yes, we found this complication very rare, very rarely. I remember less than 5 cases. In these cases, we normally start with external shunt, because in some cases it was temporary, and then after the edema, after the resolution of edema in the posterior fossa, also the hydrocephalus resolved. Only in very few cases we had to put a final DVP shunt, and this was the treatment in those cases with the success.
Yes, Professor. Go.
Very few. Very few. In my opinion, one of the trick, I mean, not the trick, or one of the point for avoiding hydrocephalus is a very good hemostasis. A very good hemostasis, no bleeding in the ventricles, and a clean surgery prevent from hydrocephalus. Anyway, it's a possible complication, of course, and we have to treat in the best way, case by case.
And what about when the tumor has a cystic component, Professor? Sometimes we see vestibular schwannoma with a large cystic component. Does it change?
Yeah, we published recently on World Neurosurgery our experience on cystic schwannoma. Cystic schwannoma is a challenging situation. So we can have different cystic schwannomas in relation to the position of the cyst. Some cases we have arachnoid cysts just peripheral, and this is not a very big challenging tumor, because you can open this arachnoid, you have the suction of the CSF, and is as classical. You have a classical vestibular schwannoma. In cases you can have inside the tumor or in the close to the capsule of tumor, the cyst. This could be challenging, especially if this is close to nerves, especially to the facial nerve. And in some selected cases, I had to leave some capsule of the cyst adherent to the facial nerve. The results of cystic vestibular schwannomas are a little bit less good than the classic and solid vestibular schwannomas. The difference is not so high, but anyway, it's a little bit more challenging situation, this for sure. Yeah, we have I don't remember, it's about 35 cases in 260 cases reviewed recently.
Thank you very much, Professor. You answered all the questions, and we have enjoyed your presentation. It gives a lot of insight about the advances in handling the vestibular schwannoma. We thank you very much for being with us. It was an honor and a great pleasure, sir.
Yes, it was a pleasure for me.
And thanks for the audience from different parties in the world. And see you soon in another activity from Avisa. Goodbye.
Thanks a lot, Professor Mohammed. It was a pleasure and an honor. Yeah.
Thank you
Bye-bye.
very much.
Bye. Thanks.